Okay, is everybody ready to get started? Okay. Thank you guys for braving the weather. Obviously, as you can see, not all of us have boats, and so as it stands right now, we don't have a quorum. But nevertheless, I think we have some very interesting informational components that'll help us out in this meeting. I've done a quick roll call. Dr. Cravens is excused, and I think that's it. First up on our agenda is discussion of a report from the Texas Council of Cardiovascular Disease and Stroke. We met just a few weeks ago, and as you know, the legislative session is ongoing right now, and so our primary focus has been on trying to obtain more monies for GTAC, the RACs, stroke, and STEMI care for the state. The basic plan had been, and still is, to demonstrate disease burden and to show where there are areas of need, and then how can we fill those, and then what monies do we need to do that. Part of the evolution of what I've seen, though, is that in addition to that, we need information to show return on investment. And we need everyone's help to lobby our legislators then to get these funds. In that regard, because I think that's the sentinel important thing that GTAC and this committee and all of us are doing right now, I was hoping that Dinah Welsh could come up and give us an update on the legislative session and where things are. And even though there are only a few weeks left, I think you'll find it amazing how much smoke there still is.
Good afternoon. Well, I have just come back from the Capitol, and I would bring you their greetings, but they're a little too crazy and focused on other things to offer their greetings to us. But we did have some good opportunities at the Capitol this afternoon. The big thing, and I know some of you all heard me speak this morning, but the only thing that the legislature has to do is pass a budget. That's the only constitutional requirement that they have when they come to town for the legislative session. If they don't complete the budget, then that's an automatic special session. And so we're all hoping that that doesn't happen. This is not unusual for any other session, that we are 19 days away from the last day of session, which is June 1st, and they are still light years away from each other. The process is such that the House passes a version of their budget, the Senate passes a version of their budget, and then the two have to merge. And so that's where we are now, is the conference committee report period, or conference committee members are meeting. There are 5 senators on that conference committee, and there are 5 House members on that conference committee. And there's some issues that are sort of core issues that generally they match up pretty closely with each other, but then there are some significant chasms in how they approach everything from border security to hospital financing, et cetera, and so and education and everything else that's thrown in there. Of particular interest, I know, to this committee is there are some provisions that are funded at different levels in the House and Senate version. There is a cardiovascular disease and stroke amendment or rider that's in both the House and Senate versions, but they are a little bit different. In both versions, there is $4.5 million that is set aside for Lone Star Stroke Program. On the Senate side, there's an additional $500,000 that's set aside for cardiovascular data collection, cardiovascular disease and stroke initiatives. but it's really focused on data collection. On the House side, similar rider that is focused, that has the $4.5 million for Lone Star Stroke, but they put in $2 million for data collection efforts and other cardiovascular initiatives. And so in marrying the two versions, TTAF, one of our initiatives has been for additional funds for stroke and cardiac care. We are obviously very interested in seeing the House version, the extra $1.5 million that's in the House side. In the last couple of days, I've gotten some positive feedback about that. However, it really is going to be up to the Senate to see if there's a Senate champion that steps up and really owns that. Dr. Rutledge, he earned his lobby stripes. I shouldn't say that, but he is a very good advocate. Y'all should be proud of him. He definitely has worn some shoe leather up at the Capitol this session, making visits, trying to figure out and understand the legislative beast. I know it's frustrating, but y'all should be very proud of him because he did take the time to go up there on a number of occasions to go talk to just anybody that would listen, but has gotten some good feedback from Senator Schwertner, he's from Georgetown. He happens to be an orthopedic surgeon and very intelligent. He is the chair of the Senate Health and Human Services Committee. He is on the Budget Conference Committee. He's on Senate Finance. So really anything that has to do with healthcare and financing is running through him at some point in time. And I have to say that Dr. Rutledge got some good play and understanding of the needs. However, the Senate chose not to add the additional funding in, and that's not a direct reflection by any means on Dr. Rutledge's efforts or anybody else's. It's really the way the Senate put their budget together. They did more of a bare bones type of version, and any of the additional funding is in the House side at this point in time. So they are now working to reconcile the two differences. We also have the whole tax discussion that's out there. The bigger tax cuts, the less money there is to spend. Less money there is to spend, less there is for all of our pet projects, whether it's hospital funding or EMS funding or RAC funding or stroke or cardiac funding. All of that plays together. And that's where it's not unusual that we are in these last few weeks of session and it's still a big question mark of if they will pass a budget, because there are just so many factors that they have to weigh in. TTAF, we have also been very focused on trauma system funding. The good thing for us, and when I say us, is the trauma system, is there's been a lot of positive feedback that's been out there about the trauma system and the need for funding. There is a lively discussion at this point in time about using some of the trauma dollars that are sitting and putting them up for matching funds for disproportionate share, and trying to make sure that there's dollars going to those trauma hospitals, but how they do that is a little interesting. But in that discussion, one of the concerns I have, because that's a big macro level discussion, is to make sure that some of these other issues that are very important to trauma and emergency health care, whether it's RAC funding, EMS, stroke, cardiac, disaster preparedness, EMTF funding, that those things remain on the table, that they don't have dollars go to the hospitals and wave the flag and say, well, we did something for trauma. Yes, but. So we're trying to keep that in the conversation, is the additional dollars that we think should go to the rest of the trauma system as well. There's one specific item that I'll mention that we're working very hard on is RACs. We know what they do for trauma system development, cardiac systems, stroke systems, disaster preparedness, EMS, et cetera, et cetera. There is a line item appropriation that is in the House version, House request version of the budget bill, and we're hoping to get that through. And again, I've had some good conversations. I continue to be very hopeful for that, but I also recognize it's politics, and just because you have the best argument does not mean you win. I think that's one of the things that Dr. Rutledge has seen up there is the teams of lobby groups that are up there. And we were just having a conversation beforehand of not necessarily any of the healthcare lobby groups, but one that he mentioned was AT&T, and I'm not trying to take your words, but AT&T probably has more lobbyists employed up at the Capitol than any other organization. Some of them are full-time AT&T, but then they have a lot of just contract people that work, certain senators, certain representatives. But I think one of the things about a session is you're obviously trying to pass legislation. You're obviously trying to position yourself well as far as a budget, but you're also trying to position yourself for the future. And regardless of where we end up, and this isn't me just trying to convince you all that we've done a good job, but I think we have put ourselves in a much more favorable position than we were 120 days ago when the session started. And so how do you sustain that once the session's over with, determining what are the next steps? And that's irregardless of if trauma gets $200 million and the RACs get $20 million. I think there's still a postmortem of how do you continue that funding, how do you account for those dollars in 2 years, and how do you make the case for additional dollars for other systems of care that we know there's a dollar need there. Dr. Rutledge, I will pause, see if there's any questions that you have at this point.
So yeah, my first question I think is what I hope everyone's asking, and that is, if we want to try to get more money for GTAC and the RACs, who do we call? What do we do?
Very good question. So right now, we are very focused on the budget process, and there are, as I mentioned, there are 5 senators that have been named to the conference committee, and there are 5 House members. The 5 senators are Senator Jane Nelson. She's from Flower Mound. She's the chair of the Senate Finance Committee. Senator Chewy, or it's Juan Chewy Hinojosa. He's from McAllen. He was the vice chair of Senate Finance. Senator Lois Colcord. She used to be a representative. Senator Lois Colcord, she's from Brenham. Senator Charles Schwartner that I mentioned, orthopedic surgeon from Georgetown, and then Joan Huffman from Houston, Senator Joan Huffman. So those are your 5 key members on the Senate side, and if I happen to mention your local area, I cannot stress to you how important it is that you all get involved with helping to push some of these initiatives forward. On the House side, there are 5 members. Representative John Otto, he's from Dayton. Representative Sylvester Turner, he's from Houston. He's the vice chair of House Appropriations. Trent Ashby, Representative Trent Ashby, he's from Lufkin. He's focused on education. Representative Sarah Davis, her district happens to be right in the middle of the Texas Medical Center, so she is very healthcare focused. And then Representative Larry Gonzalez, he's from Round Rock, and he is focused on pretty much all articles except for education and healthcare. So those are the 10 members, sort of like the 10 finalists of the Miss America Beauty Pageant or something. Those are the ones you really got to focus on now. If you are not, and this is not a TTAF plug, but it is sort of kind of, in that if you are not getting our action alerts, go to our website. It's pretty easy to sign up to get those action alerts. For those of you all that have anybody received an action alert from us and actually responded? So it's really pretty cool is that once you respond and you enter in your personal home information of where you live, every time you get an alert from us in the future, it populates all of that, and you can send an email immediately. We've had some very good success. We've gotten great feedback from legislators that they are hearing from us on different issues. We've done action alerts on everything from cardiac and stroke funding to there's distracted driving bill, no texting while driving bill that's up tomorrow in the Senate. And so if you're not getting those alerts, I would encourage you to sign up on our website. There's no charge, and we won't sell your name or anything like that, but it's a good way to be in communication just with what's going on. But contacting those legislators, when we do send out the action alert, to feel free to click on it and send your message, but then also to find legislators or find people in your area that do have relationships with those legislators. It certainly doesn't hurt. But we've got several areas that we're pushing on. The whole trauma system funding, the RAC funding, cardiac and stroke funding, and EMTF is also another area that there's some funding out there that we're looking to get as well. So it comes down to the conference committee. Speaker Joe Strauss, he's also a key person in all of this, as well as Lieutenant Governor Dan Patrick. They are key in where all of this will land. Does that help?
Yeah, and I would say this is really easy to do. You just pick up the phone and call. It's not hard, or send an email. And even going up there is not that difficult too. If you only stay for, I think it's an hour, 2 hours, it's free parking. you walk through the Capitol. It's like going through airport security, and there are little maps, and you go to wherever the senator's office is, and you walk into the office and you say hi. Here's why I'm here. And you find out that there's some college student who's a sophomore who's deciding where $20 billion is going to, and you talk to them, and you know way more than they do. And just one or two people doing this could be the difference whether we get a lot of money for the RACs, which is what we want to do, or not. So, yeah. 19 days.
Yes, 19 days. And if any of you all have a strong desire to go to the Capitol, Courtney DeBauer and I can be your lovely tour guides, and we'll walk you around, introduce you to all kinds of fun people. Daryl Pyle's I've been following him around actually today. But anybody that has an interest, and in the interim, we go up to the Capitol too, and we can even do dome tours if y'all want. But you got to come play when the legislature's in town too. So, but I know politics. I know legislative processes. For a lot of people, it becomes an eye roll, and it's frustrating because the best argument doesn't always win. But I cannot encourage you enough that if we don't show up, if we're not there, that is an absolute guarantee that we will not be funded and we will not be heard. And so that's the only way that I know of for us to actually move the ball forward, is for us to be up there in force. And I do think we are making headway. And again, I'm still optimistic about what the outcome is going to be for this session. But regardless of where we end up, I know we've put ourselves in good standing for upcoming sessions.
More questions?
One thing I was just thinking about, Dr. Rutledge, I had mentioned AT&T and just their band of lobbyists, and sort of think, well, what Dr. Rutledge was talking about, which I think is a good idea, is you've got a lot of lobbyists out there, and we've actually experienced this with the no texting bill. Is there's a flyer that's going around that, it has TTAF's name on it, but it has probably 50 different organizations on it. 20 of them or so are probably Fortune 100 companies, which is great for us to be part of. But there are issues that I think some of those large corporations would be interested in wearing the white hat with us, and we need to think about those opportunities. And it's not something that I've necessarily thought of like that, but I think Dr. Rutledge is onto something that, how do we engage an AT&T or a USAA or a lot of the different insurance companies that have huge lobby teams up there? How do we engage them to partner with us to help us get the message out? Because when it comes down to it, when it's stroke and cardiac care funding and the coalition that came together, there were a lot of people that worked on that issue, but when it came down to it, Dr. Rutledge and I were the ones that were pushing forward that full initiative. And there were a lot of organizations that were pushing different pieces of that, which was helpful, but there were very few people that were actually at the Capitol pushing the whole initiative. And so how do we, yes, we've got a lot of great people sitting around the table, but TTAF does the same thing. We're pushing on our RAC funding, and if we push too hard on cardiac and stroke funding, where does that leave us over here? And so how can we help? How can we help engage more people to help carry our water for what we obviously feel is a worthy cause and a white hat issue? So.
Well, you guys don't know how much hard work she's done and what a great lobbyist you are, and thank you very much. But it is sort of like, when AT&T has like 120 lobbyists and you're like one person and you're trying to deal with all these people, it's just really not fair. And the influence by just association and friendship is also not unestimatable. So please call. It's nothing to do an email or a call, and it'll hopefully get more money for the RACs, which is what we need.
Yeah. Well, thank you. Again, Dr. Rutledge, I appreciate your support, and you've done yeoman's work for somebody that the Capitol is not your home. You've shown that you can excel up there, and anybody that has the willingness to go up there and try to make a difference, you can. And I appreciate your work.
Yeah, well, anybody can do a web crawl or a pub crawl.
Yes. Thank y'all.
Thanks. And I forgot to welcome Paul Hansen as our new committee member. He's taken over Joanna Morton's position, and we really appreciate your help. Thank you very much. Do you want to, you've spoken to us before, but can you please tell a little about yourself so people know who you are? And
yeah, no problem. My name is Paul Hansen. I'm a physician from the Dallas-Fort Worth area. I'm a neurointerventionalist, so a stroke doctor essentially, predominantly treating ischemic stroke. I'm one of those guys that goes up and pulls clots out of people's heads. So kind of the forefront of where stroke care is going in this day and age. Also deal with head bleeds and things of that sort. What makes our group a little bit unique is that we're made up of all neurologists, so we're all neurology trained interventionalists, and we cover a massive region in North Texas. So we get a lot of patients from the rural market, and that gives us a unique outlook on how to organize systems of care to help get people in so that they're ending up at the appropriate place for the best level of care suited for them. So I think that's where I can really help out and lend a little bit of expertise, is how do we design our stroke systems, how do we design our systems of care to really get people where they need to go in the best amount of time possible, because stroke, as we all know, time is brain, so we need to handle these things quickly and get people to the appropriate places. As far as a little background on me, I went to Duke University, so big Blue Devil fan. I was pretty excited when we won the NCAA tournament this year. Other than that, I've spent the vast majority of my time in Texas. I actually grew up in Round Rock, so I'm pretty close to home right now.
Very cool. I'm going to skip around in order a little bit, and you'll understand why. But what I'd like to do next is the presentation review of survey data from DSHS. Also, you'll tell us a little bit about NMSIS and to sort of give you an idea of where I'm going with this is after this, I want to solicit your all's suggestions in regards to what data needs to be collected. Obviously, we want to collect data to do better. We want to collect data to try to get more money from the legislature. And this will let us sort of give us an idea of where we are. And thank you. So please.
Thank you. Good afternoon. My name is Carla Granado, and I'm the project coordinator for Rider 97. I'm going to do a quick program update, and then I'll pass it over to Suparna from the Office of Surveillance, Evaluation, and Research to do a data presentation. So in terms of Rider 97, we continue to expand the reach of hospital systems participating in the data collection project. And we currently have 55 hospitals that are signed up for the heart attack component and 47 for the stroke data. We're working in conjunction with the American Heart Association to host a conference for participating hospitals and potentially those interested in participating. The conference name is Heart Attack and Stroke Systems of Care Summit, a focus on quality improvement through the Texas Heart Attack and Stroke Data Collection Initiative. And it will be held on July 24th here in Austin. An agenda is being developed at this time, and Dr. Rutledge will help us kick off the day with opening remarks. In terms of data, as you remember last year we surveyed the RACs on their heart attack systems of care. This year we surveyed them on their stroke systems of care. This survey went out to all 22 RACs and covered different topics such as RAC data collection practices, resources, and quality improvement activities. All 22 RACs responded, and the critical findings were related to resources and needs identified by RACs. The RACs were asked to describe their resources to perform a variety of functions. Most RACs reported that they did not have enough resources to provide community and professional stroke education, collect and manage data, engage stakeholders, and increase their participation in RAC activities such as reporting data, provide training opportunities for EMS personnel, and perform EMS stroke response and care or equipment and personnel. The RACs were asked to consider the same functions and rank them in order of greatest need. The RACs said they needed resources the most to provide stroke education, to collect and manage data, and to engage stakeholders. The second analysis of hospital data is complete. The stroke and heart attack hospital performance reports have been uploaded to the Texas Heart Disease and Stroke Program website under the Council Projects tab. The link to the reports has been shared with stakeholders, including the Rider 97 data consultants, the American Heart Association, hospitals, the regional advisory councils, GTAC, and the CVD Council as well. And now I'll pass it over to Suparna for the data presentation.
Good afternoon. My name is Suparna Bagchi, and I'm within the Office of Surveillance, Evaluation, and Research. During the 83rd regular Texas legislative session, funds were appropriated to advance the heart attack and stroke reduction efforts throughout Texas. To inform such efforts, the Texas Council of Cardiovascular Disease and Stroke has launched a heart attack and stroke data collection initiative. The data collection initiative focuses on the pre-hospital and hospital data elements. This report includes de-identified aggregate data for hospitals who have agreed to share their acute coronary treatment and intervention outcomes network, or the Action Registry, Get With The Guidelines data with the Texas DSHS. All data are protected under the HIPAA guidelines. This aggregate data is intended to inform stakeholders about the opportunities for collaboration and system enhancement. The objective of the data collection initiatives are to gain an understanding of the prevalence of heart attack and stroke in Texas, evaluate the pre-hospital components of care, and the treatment of heart attack and stroke patients. Findings from this will be used to assess the policies and practices regarding delivery of care across the state, identify areas of opportunity for quality improvement while recognizing the achievement among the hospitals. For the purpose of this presentation, I will be focusing on the elements of stroke care. The data were collected with the Get With the Guidelines stroke database from Quintiles and reflect the hospital care from October 2008 to September 2014 from 38 participating hospitals. Data were analyzed for the reporting, quality, and achievement measures for effective care for stroke patients. These measures were selected through collaboration with the Rider 97 consultants. The measures with an asterisk on this slide were added after the first report was published based on the feedback from the data consultants. Between 2008 and 2014, 50,059 cases of stroke were reported by the participating hospitals. Ischemic stroke, which constituted 65.7% of all strokes, was the most common type of stroke among Texas adults 18 years and older. Other stroke types included the transient ischemic attack, which constituted 15.3%, and intracerebral hemorrhage, which constituted 10% of all the strokes. The median age of stroke patients was 69 years, and slightly more than half of the patients, or 51.4%, were women. Among the cases of stroke that occurred during the time period of our study, 34.8% of the patients were transported to the hospital by a private vehicle. Thrombolytic therapy using intravenous tissue plasminogen activator, or IVTPA, is the preferred reperfusion strategy for patients who have had an ischemic stroke where a blood vessel is blocked by a clot. Time to the IVTPA is often referred to as the door-to-needle time. An ischemic stroke patient should receive IVTPA within 60 minutes of arriving at the hospital. Among the eligible ischemic stroke patients, 56.6% of the patients did not receive an IVTPA within 60 minutes of arriving at the emergency department. Among 31,788 patients with ischemic stroke, 376 patients, or 1.2%, had received IVTPA at a community hospital, followed by being transferred to a comprehensive stroke center. Among the 31,788 patients with ischemic stroke, 309 patients, or 0.97%, received IA catheter-based reperfusion either at an emergency department or as an inpatient or outside the hospital. Among ischemic stroke case patients who received IVTPA or IA catheter-based treatment, 5% of cases, or 170 patients, had bleeding complications after receiving the thrombolytic therapy. Approximately half of the patients, or 52%, were discharged to home, and approximately a third, or 33%, were transferred to another healthcare facility. Among patients transferred to the other healthcare facility, more than half, or 58.7%, were discharged to an inpatient rehabilitation facility, and approximately a third, or 33.8%, were transferred to a skilled nursing facility. Here are some of our references, and for the next part, I will be deferring it to Chris Drucker for NEMSIS presentation.
I have a quick question first. So when we look at demographics for the whole state, for the number of strokes that occur in Texas per year, we're just looking at the hospitals that reported as just 50,000.
Right.
So if you could, what does that represent for the whole state? I mean, what percentage or portion of that? I mean, 50,000 isn't that reflective of the whole state, correct?
No, this is only from the hospitals that are participating, the 38 participating hospitals.
And we have like 250 hospitals?
Right. I'm sorry, I don't remember the exact number.
136 stroke centers, but like 250 plus more hospitals. So this is still just a sample of the whole.
Right.
Because I'm sure San Antonio would be doing much better if we had all the San Antonio hospitals, right? Okay.
Dr. Rutledge, were you noting all hospitals in Texas? Because there's almost 600 licensed facilities that could receive a stroke patient.
Yeah, I'm sorry. I was thinking it's like 250 Torch hospitals, the small hospitals, but you're right, 600. Right. So I mean, we're talking a small number of the whole, but I mean it's a snapshot. Nevertheless, that's just what I wanted people to understand. It's good.
The 31,000 that were the drip and shit therapy, were they part of that 50,000?
Yes. Right.
It was like 50,000, then 30,000 ischemic, and then of those 376, only 1% were drip and ships, but we don't know which hospitals were in and which were out.
Just as a breakdown of the number of hospitals.
Can you use the mic again? I'm sorry.
Just for our ongoing edification, can we get a breakdown of the number of facilities that are part of the data collection? How many of those are comprehensive? How many are primary? How many, I mean, not today, but in the future, just so it kind of gives us an idea of what we're looking at there.
Yeah, I think that's a great idea. And if we could, if I could repeat that, the request is to get an idea of who these hospitals are, sort of where they are, what level of treatment they're doing. It's great. So
Do you break down by year?
oh, it's all that last year.
6 years.
Oh, was it several years?
Yeah, 2008 or 2014.
Oh, I'm sorry, you're
So
right.
8 to, yeah, so if we can
Right.
break down by year.
Our next report is actually going to have yearly trends. So we're improving the reports as we go and updating them. So.
Dr. Rutledge,
Yes, sir.
I'm glad to hear what was just said, because just in Houston alone, when you say a snapshot, this study reflects ischemic strokes at a rate of about 695 a month. And we've got more than double that in Houston alone. And I am interested in the data on a yearly basis, because it might have started to get more robust in recent years as compared to the early years of your study. So it's a great study. I congratulate you on that. But I'm hesitant to rely on any conclusions at this time.
Particularly on
Thank you.
endovascular treatment.
Does anyone have thoughts? One of the discussions I know that was going around the DSHS is ultimately how frequently these reports should be, monthly, quarterly, 6 months, yearly. Anybody have thoughts or want to comment on that?
I think quarterly.
Quarterly?
Quarterly.
Okay, quarterly. So the next question is, how do we get better data? And I think this little presentation may show us the way. So,
Correct, Dr. Rutledge. Dr. Rutledge and members of the committee and everyone else here. I am Christopher Drucker. I'm the manager of the Injury Epidemiology and Surveillance Branch with the Department of State Health Services. I'm going to talk a little bit today about the EMS and trauma registry system and how it can be a benefit for data collection and be a benefit for the goals and objectives of this committee. Quoting a stakeholder about 45 minutes ago, it's good to see that our reports are now including medical data and not just trauma data. And so we want to continue on this path. Just a little overview about the EMS and trauma registry system. We collect a variety of data, and I just want your attention to be on the far left side of the screen. That's EMS runs. All EMS runs are to be reported to the EMS registry, and we get approximately 2.6 to 2.7 million EMS EPCRs annually. From a presentation earlier today in the pediatric committee, more than half of these runs are identified as medical runs. About 20% of them are trauma, and about a quarter of them are not known or classified as not applicable. But more than half of the data that comes in is medical runs. And it's by statute and rule that we collect this data, and this has been told before, so I'm not going to talk about this. But I want to talk about the type of data that we do collect right now with the EMS registry. We currently have what we call our legacy standard, which collects approximately more than 130 data elements from EMS providers. And within these data elements, we have specific data elements such as primary and associated symptoms, which has specific values in there to identify stroke patients and STEMI patients as well. This legacy standard will be phasing out this year as we transition into our NEMSIS V3 standard. I could say that we're not that far from being a NEMSIS V3 state. We're currently waiting for the NEMSIS TAC to break our system. If they can't break our system, then we'll be given that certification approval. And so any day today, we'll find out if we're certified and can start collecting that V3 data. Now, within that V3 data, there's identification of stroke and STEMI runs in there. Specifically, there are 109 data elements designed for stroke performance measures and 116 for STEMI. And as I just mentioned, we're going to be implementing this. Once we are certified, we'll be able to start collecting data. Then in time, we'll be collecting this V3 data from all EMS providers. In addition to the national data standard, we also collect what we call Texas custom questions. And we have custom questions for EMS providers, and we also collect custom questions from hospitals. But for our pre-hospital data, we currently have, I believe it's 32 pre-hospital questions. And my staff can tell you more exactly how many custom questions that is. And these questions were derived from identification of a specific need for data collection. The bulk of these questions, I believe 27 in nature, are related to submersion events. And so there's opportunities to add questions, to take away questions from these Texas custom questions if there is a need within the EMS community, within the trauma community, with any other communities that we collect data from, to better ascertain the impact it has on the pre-hospital and trauma systems of care here in Texas. Currently, with our pre-hospital data, so that's our EMS data, we have data available from 2010 all the way up until today. If an EMS provider sent us data 5 minutes ago, we'll have it in our registry available to extract, available for our analysis purposes. Some of our data sets are already closed from years 2010 to 2013. They're closed, meaning that we already pulled our final extracts of those years, and that data is what we use for our reports that we present at these various committees and we have on our website. We still are collecting 2014 data, and we're still in the middle of 2015 data. And so the purpose, I think Dr. Rutledge, you had me present, was to talk about how we can use this pre-hospital data that my office is collecting through a legislative mandate, and how we can supplement that with the stroke community, with the STEMI community, and how we can use that data to further advance this specific type of outcome.
Right. So right now, through Rider 97, we've been requesting information through the racks to help us get at this data. But with this system, we can get that data through NEMSIS, at least the pre-hospital, the number of runs. And so that frees us up to use money for the racks to either help with education or do other data collection. Part of this also is, we just had a report on the number of hospitals data. I mean, there's two parts to this. It's getting people to the hospital and then what happens at the hospital. And so the other part is, how do we get the data from the hospital so that we have the full picture of what's happening to these patients?
Correct. The pre-hospital component, we already have it in statute for my registry to collect that information. Now, the collection of stroke data from hospitals requires a lot more work, requires statute changes, authority of who to collect it. And so it's a lot more that's going to be involved with the collection of stroke data from hospitals. But for pre-hospital data, we collect all EMS runs.
And some of you guys may not know, some of the hospitals are a little abashed to share this data, whereas others already have reciprocal relationships with EMS groups, like, for example, would be Williamson County here in Central Texas. They already have relationships with the hospitals and the EMS to correlate the data. And you can be very sympathetic to some hospitals. If you're if you're in Houston and you're a large hospital and you're getting the sickest of the sick stroke patients, your outcomes may not be as good as some place that's more rural or frontier area that's getting less sick patients. They may show better outcomes. So I think the outcomes data has to be stratified as well, so that you know how sick the patients were coming in as well as going out. But the whole purpose of this is to hopefully generate a discussion, and I wanted to see if other people have thoughts or want to chime in.
These 109 data points that you have in the system now, did those come from like the Get With The Guidelines kind of
So the 109 data elements for stroke PMs, it's what the NEMSIS organization has identified. Now, these are not 109 specific elements to stroke. They're used for pediatric use, for STEMI, they're used for the other 5 or 6 PMs that they identified. And they can help with identifying information for transport service times, for different type of acute care information. And so there's 109 elements that can be used for stroke evaluation. STEMI has 116.
So what he's saying, another way to say this is, there are potential data elements that we can request to be put in. And so if you're like me, oftentimes I can't ever think of anything when I'm on the spot, like if you're sitting out there. But this is a solicitation for data elements that you think might be important. We have data consultants for the Texas Council of Cardiovascular Disease and Stroke, but really this committee, the RACs, that's also important, is what data you guys feel will help you either locally or then legislatively. And so let me add 2 other things so we can sort of combine everything and get us out on time. So one of the agenda items is solicitation for data collection elements for next year for the Rider 97 monies for the RACs. And then also, if you guys don't know, Brian Eastridge currently is working on the strategic plan for the Texas emergency healthcare system. And this is basically an overview of what GTAC does. And it includes stuff like burden of disease in Texas for cardiac, stroke, Texas injury, what the overall mission is for GTAC, and then the critical elements that we see that we need to improve. The transport plan, the education plans, the communication, all that. So at this point, although it's a little out of order, if people have recommendations on data elements, there's no such thing as a bad recommendation. Would like to hear it, and we've got people that can tell us if we can do it or not.
I didn't specifically think about the data elements, but I can think of a lot of them. So Chris, I have a question for you. The data that was presented to us is aggregate data, but does the state get that by patient? So you get the full patient data set for all of the patients, true or false?
For
For Get With The Guidelines and an action registry. You get well, I understand that, but, okay, so
Carla?
do you guys get patient level data for how many patients, 50,000 patients that were there? So then, you guys, since she has that data set and you have the patient level data from the pre-hospital provider, can we connect the dots?
Yeah, I mean, yes, that's what the Texas Council of Cardiovascular Disease and Stroke did.
What?
In a way, though, that still preserved anonymity. Did it in large regions and stuff, and there's actually some maps that have been generated, although they're not as perfect as we would like. I think moving forward with that is the gap analysis that all this ultimately builds on.
My suggestion is that by combining those two data sets, the reports will be so much more robust, that we're able to talk about the continuum of the patient's care, not segmenting it. She's just getting hospital data and he's just getting EMS data. And we know that our patients are way more than that. They're all of our data. So that would be a great collaborative work from people who work for the government.
But Dr. Rutledge, did you just say the CVD Council is already linking that data together?
Well, we did a report where we did a legislative report where we did show the EMS runs.
Right,
versus
patient.
Yeah, we did not. No,
We do,
and that's a registry, and we didn't have the hospital data to do the
That's
outcomes.
what she's saying, though. They
Yes.
have the hospital data and he has the EMS data.
The
Right,
prob-
and I think that's a good idea. Go.
The
ahead.
problem is that we, with our data use agreements, with Action Registry, the two vendors, I'm forgetting their names, but it is de-identified data, so I don't think that we have the capacity to link to the pre-hospital data. That's the nature of the agreement that we have, is that it's all de-identified data.
It's possible to link de-identified data based on event information, but your degree of certainty just falls to the floor.
Right. I mean, this comes the difference between data collection and a survey. All these deals are not following an individual patient all the way through, but you can still do region analysis, temporal and geographic analysis that associates but doesn't correlate the events. Correct? Like, for example, you know how many EMS runs are done in a specific area over a quarter. You know from the hospitals how many patients are being discharged and in what manner they're being discharged. There's an association but not a correlation because you're not following the specific patient.
Correct. We could tell you the number of patients that occur in a specific county and whether or not they're taken to a facility within a region, and then you can look at the hospital data and see how many of those patient records come from that region. If you're having 10,000 stroke runs, patients being delivered to a facilities within a specific region, and then the hospital data only shows 100, you can see the difference there.
It's a great discussion.
So, a couple of things. Carla, anything that we have sent to you as we've been doing the data collection changes, are you saving all that to provide forward because we found some discrepancies on particularly reporting and that they're less than zero. I mean, I'm from Waco and we've provided several, but we haven't adjusted the rider stuff. So are you maintaining that so you can provide that to Dr. Rutledge of some of the issues that have come up about the data discrepancies? Okay, perfect. And then the second thing is, what data element will you pull from the EMS run to ensure that it is truly a stroke patient? Because a lot of pre-hospital runs, they may initially go out as a chief complaint of possible stroke, but when they get there, it's a diabetic issue, or they go out for a fall. Well, they really had a fall because they had a stroke. I mean, do you see what I'm saying?
The data element that we currently use is primary and associated symptoms, which are specific values for stroke. And so that's what we currently use with our legacy collection.
Can you do a presentation on those
Yeah.
for us next time?
Because I'm not sure we're getting as good of data as we think we might be getting. Not that they're not entering the data correctly, they're entering it exactly as it comes in as the run, but I'm telling you that dispatch and how they get sent initially to a call doesn't always match
Correct.
the end result that the hospital finds out.
Well, if we
when
can
they
also
get there.
highlight the ones that are gonna be looked at specifically for stroke or STEMI, and we get that information to our EMS, I think we're gonna get better data back in.
Girl, you got to go up there, I had to hop up there.
So why don't we kill two birds with one stone and use this to drive outcome feedback to our EMS so that we don't have to have this conversation?
Yes.
How do we get the hospitals to do that?
Oh, I'm working on that. I'll be presenting off on it in the next one. Thank you, sir.
Okay, okay. Any other thoughts?
Just a question, do we
Yes.
have any data about the effect of neurointerventional?
Sure. Actually, Paul just gave that to us last time, but it's basically twice as good as IV TPA. Would be a quick down and dirty. Paul, what would you say?
How many hours?
Yeah, there's about 7 studies. I think when I came up here and talked, I can't look at you and talk in the mic at the same time. When I came up and gave the talk, there were about 4 studies that we reviewed, and there's 7 studies now. All of them are coming down very heavily on the side of neurointervention. And that's with the caveat of most of those patients get TPA as well. This is not a replacement for TPA, it's an augmentation or in addition to TPA, except for those patients that present outside of the TPA window. There's also some pretty rigorous data points that need to be met whether or not they would qualify for going to the interventional suite. So essentially, we only take patients that would stand to benefit, and we don't take patients to the angio suite that wouldn't benefit. But mortality drops. There's the patients essentially do twice as well. It's a massive improvement compared to TPA alone. Part of it is the time window's quite a bit bigger. There are some sites that will go out to 12 hours. The majority of the studies were done in the 6 to 8 hour window, though. Well, not in the 6 to 8 hour window, the 0 to 6 or 0 to 8 hour windows. So there's still relatively acute onset strokes, but you've essentially doubled the TPA window in order to treat those patients. So
Does it vary by size of stroke?
it does. So if I always like to think of the blood vessels like a tree. Okay, so you've got the trunk, that's your biggest vessel, and then the trunk is going to branch out. You've got limbs, branches, twigs, leaves. Okay, so if you see a stroke where just a couple of the leaves are gone, there's a lot of potential to save a lot of brain there. If you have a very large clot in, say, the carotid artery, you've taken out the trunk. It may be that by the time that patient gets to the hospital, even if they receive TPA, the stroke may be so big that even if you were to take that clot out, the damage is already done. So there is that. But by and large, if there's brain left to save, our group is pretty aggressive about going after those. And there's a lot of studies still ongoing now trying to better quantify which patient should go, how far out can we really extend that time window. It's going to make a big difference across the board, but it's a pretty new technique. If you look back 5 years ago, there weren't a lot of people that were fans of it. So that it's slowly changing, but I think the preponderance of evidence is going to become so large. It is becoming so large that it's a tough procedure to ignore.
Yeah, the next place that I think will fall is wake-up strokes. And they'll need perfusion imaging for those. But I think you'll see that fall within the next year or two as well.
There's a study called DAWN that's going on right now, and it's out to 24 hours. And it's specifically designed to capture those wake-up strokes where the last known normal was 8 hours ago or more. So they cannot get TPA. You use some computer program to decide whether or not the patient is eligible for the intervention based on MRI. But
all these will affect our transport plans, and that's a good way to go into our report from our transport plan committee, unless there are other recommendations on data elements.
Yes. One thing. I'm really pleased to hear you get on this before the data is even gathered from NMSIS. And I wasn't ready today, and I don't think Catherine's ready today to give you a whole list of things that would be good to have in this study. But if we could have a week or a couple weeks to submit ideas to you, that would be wise. And then we could set up a report that we want to have generated as soon as this data starts coming in. And we could actually be involved from the get-go. We have had a problem in the past with getting data out of the registry and out of the state. So I'm also glad with that presentation as well, because it's kind of implied that the data will be shared with us. And I hope I'm not reading into something that's not there. And finally, I suppose we should, if it's available, study the number of minutes that it takes from the point in time the patient it's called in until that patient gets to the receiving hospital. Minutes would seem like an important factor. Thank you.
I think also, if I may, in planning the systems of care, and too important, you mentioned something just now, it is endovascular therapy certainly has opened the door for more patients, but it is not replacing TPA. And in fact, and most of those, in all of those studies, most of those patients received TPA before they actually got. And for those that did not get TPA, although they did better, they didn't do as well without the TPA. So that's something to keep in mind. And I think an important, to be able to provide recommendations in terms of what data points are useful, I don't know, but it would be useful for you guys that have the data to share the data points that actually you collect, to be able to and go from there and say what is it that we would need to be able to add something that might be useful. That's one thing. And the other, I think, an important part of data collection in terms of deciding, at some point we're going to have to make a decision when it's going to be appropriate to bypass hospitals. We would need to know, and since most of patients will still, those eligible for TPA will still need to get TPA, it would be important to know the time that it takes. If somebody gets taken to a primary stroke center that doesn't have intervention, how long does it take? How much time is wasted, if you will, or spent from the time that the patient is in the drip and ships, in other words, I mean, to the comprehensive stroke centers. So to try to estimate the distances and times that are appropriate in terms of metrics, and that will help decide when is appropriate to bypass hospitals. And with that in mind, I think it's going to be important for EMS to be armed, because in most of the studies that had a endovascular, and all these endovascular studies, most patients had an average of 15 or 16 on an NIH stroke scale. So we don't know, although there are many that have a low NIH stroke scale that may have an occluded vessel, we don't know whether they necessarily do better or worse with endovascular therapy. And so I think it's going to be important to try to have the EMS identify those that have a large deficit, that are the ones that perhaps would at some point have to go or bypass primary stroke centers to comprehensive stroke centers.
And I think, while we're considering that, we also need to include the medical directors for those EMS systems too, because they are the ones that will ultimately write up the protocols for that.
Yeah, actually, I want to echo that. You know, the medical directors, we make recommendations. And the RACs make recommendations. It is the medical directors that ultimately determine how their trucks run, right? So go ahead.
So Dr. Rutledge, possibly to help your committee with data element generation, what we can do is we could send to you to distribute amongst your committee members a spreadsheet of all data elements that are identified as part of the stroke PM for NMSIS.
Right, and then we could distribute that to everyone, including the RACs, and continue to solicit for their input on what they would like. That's a great idea.
Okay. question was, are any other Texas custom questions stroke or STEMI? There's 32 questions, 27 of them are submersion related. I do not believe the remaining 5 are stroke or STEMI related. Zero. Confirmed.
Okay, and to speak to the hospital side of things, in Get With the Guidelines Stroke, there is an entire tab dedicated to pre-hospital data elements. They are considered optional. In several of the racks, what they are doing is making some of those elements required, including the drop-down list for the agency name and the run number, which will enable them on a local level to marry that pre-hospital and hospital data. So that's something to consider. And in the action registry, Get With the Guidelines side, the heart attack side, there are also similar elements that have been recently introduced too.
Do you know if the heart? I'm sorry. Do you know if the heart committee or the STEMI committee for GTAC have they talked about combining that in the action registry?
Not that I recall at the last meeting, but I
Right.
do know that there was an introduction of those pre-hospital elements. They were only recently introduced in January, February, added into that tool. So.
Talking about the data sets and outcomes and so on, the question, do we have any idea of what is the proportion of hospitals that have in Texas that have are associated with the guidelines for stroke?
The total numbers, it was 100 and something that are enrolled in Get With the Guidelines. Really, most of your designated stroke centers are utilizing Get With the Guidelines.
Because then the
There's
question
very
is,
few that aren't.
if the state is to make a registry, is whether you have to have something that can be harmonized with it. Just as a matter of introduction, I missed the last meeting. It was my first meeting. I'm Dr. Cruz. I'm from Texas Tech. I came from St. Louis. I stayed there in about 21 years, and Missouri was struggling with the same issues in terms of having a system of systems of care, from what I remember, and they were. As they work in their process and to have a system of designation, they sort of allied, if you will, with American Heart and trying to have a registry that harmonizes both data sets. So, because in the hospital side, it becomes a problem because they may not have enough FTEs to enter data, and if they have two different data sets or databases to fill, and so that's just an idea.
That's good. Okay, so to segue into, I'm going to quickly segue into Dr. Craven's report because he's not here, and I can hopefully do this quickly and get us through in 15 minutes. Dr. Craven's committee has put forth recommendations on Texas Emergency Medical System stroke triage and transport. Here's the report right here. And they've also done a wonderful job of collecting basically what all the racks are doing right now in an Excel spreadsheet. My intention is that what we can do is we can publish this on the website and get feedback and information on this. Basically, as you know, right now, the recommendation from the state is to transport to the highest level of designated stroke center, and we recommend a bypass time. And the question is, how do you do that for specific areas? And he addresses that, and he addresses different pre-hospital stroke assessment tools, which we'll move into education in just a second. Right now, we're using the Cincinnati LA stroke scale, but LAMS is also one that's really coming into fore. And because we don't have enough time, I can't go into all the details of this report, but what I'll do is I'll publish this to the committee and distribute it, and then also put it on the website. And the idea is to solicit comments for us to move forward with recommendations in this regard. And next is the stroke education stuff, and Homer, can you update us on that?
CE thing?
Right.
Over on we moved forward. I'm visiting again with the Education Committee in the morning. Oh, sorry. Thank you. I hate this thing. I'm visiting with the Education Committee in the morning for their support. I've sent them, they requested some additional information. I've sent them some studies and some abstracts. Those have been distributed to their people, and we're going to discuss those in the morning. And as I noted, we're on the agenda for GTAC Friday to present it to them. So I think we have, I think folks have kind of understood this is not a, we have so many CEs required, and they didn't want us to get too specialized, but stroke is something that you really can't ignore. A lot of our CE, the content and what it addresses is not something that is a debilitating, lifelong process as is stroke. And we don't have anything that addresses just the stroke end, and that's all we're asking for. And I think folks are beginning to understand that's all we want, is to get something going, to make a start, and then adjust it however it needs to be adjusted as time goes forward.
Okay, thank you. And to keep us on time, are there any general public comments at this time? Yes.
The discussion about bypassing facilities, I just hope we spend the time to have really good discussion about that. We have a lot of facilities who have invested a lot of money to become primary stroke centers, and they will not go down willingly if they believe the system is coming up to detract from all of their efforts.
So again, to remind you, bypass is mandatory. Bypass is mandatory. The RACs determine how the bypass occurs, and we make recommendations. But there's no, the rule is that you have to transport to the highest level designated stroke center within the RAC rules that are set up.
I think the discussions in the RAC we're going to have to be based on how to stratify those patients. That's what I was saying.
Exactly.
I think there are more people that are going to be eligible for TPA than there will be for endovascular treatment. That said, there are those that are eligible to, and probably the best candidates for endovascular treatment, that probably should go directly to the comprehensive center. And so, and the idea is, what is the best systems for each RAC, and that's the discussion for each RAC, to decide what is the best system to best identify those patients that may benefit from endovascular treatment without causing them harm by not offering them TPA at an earlier time, because bypassing means that even if they get TPA, they're going to get it a little later. And so those are probably the discussions that the RAC will have to have.
Right. I agree.
But once again, it's not a question. It's not a question of do you bypass. The question is how you bypass. Go ahead.
I just wanted to talk a little bit about some of the things that we've done in Houston. We, with the introduction of comprehensive stroke centers, SETRAC took it as a cue that we needed to bring together our EMS medical providers and our neuro doctors together in one room to talk about how would we help EMS identify a stroke, and then how would we help them understand how they need to bypass facilities. And so one of the things we did is we brought them together for one meeting. We talked a little bit about what a RAC's responsibility is, that we do need to provide this stroke guideline information, and then we talked a little bit about what the recent literature said, which most of them were aware of. Then we talked about limitations of what EMS can do in the field, and then what the hospitals would want to see upon arrival arrival of the stroke patient. We brought them back together about 6 weeks after the initial meeting, and we had them talk about what their expectations would be and how we could marry them together. And one of the things we came up with, it's on the SETRAC website, we call it our stats tool. And what it does is it talks about the identification of a stroke, and then a little later on, it talks about severity indicators. And so what our goal was with it is, one, help EMS identify that stroke, sudden one-sided weakness, headaches, all those things that the Cincinnati Stroke Scale would use. But then what we also did is we looked at severity indicators, GCS less than 9, asymmetric pupils, severe one-sided weakness, severe headache with no known cause. So those were our 4 severity indicators that helped us understand maybe it doesn't need to go to any stroke center. Maybe we need to try to see if we can get to a comprehensive stroke center. So then what we did is we dove into what the American Heart Association had put out as far as comprehensive stroke centers and how we need to bypass. And their recommendation was that transportation should not extend greater than 15 minutes of where your original destination was. And so that's kind of how we put our protocol together. With the recent introduction of the endovascular studies that have come out with MR Clean and some others, what we're going to do is we're going to reconvene that committee of neuro doctors and then also of our EMS medical directors to talk about, do we need to further revise our protocol or not? So just some of the things that we've kind of done in Houston, the data that we're collecting right now shows that EMS is using the bypass protocol, that they do feel that it helped them better get the patients to the right facility at the right time. We have not had any kind of backlash from our primary centers saying that their volume has gone down. So right now, initially, we think that it's been successful in the area. But there's more to come. Again, it's on our SETRAC website. It's under Committee Stroke, and it talks about STATS, stats. We've got a checklist, and we also have a flow chart. So just something that we wanted to say that we've done in the region to address that.
Excellent, thanks. And I would also remind people, we're only treating about 5% of the strokes as it is, so there's a real up market for any stroke center ultimately. Other general comments? Hearing none, this meeting's at an end. Thank you guys for braving the rain.